Okay, we're going to move on now to our second speaker. So it is Dr. Seamus Coyle. I can't see him. Where? Oh, there. Oh, you look different in your photograph. Seamus is going to talk to us for a half an hour on can we predict dying. So I'll just tell you a little bit about Seamus. Seamus is an academic consultant in palliative care medicine with a 50-50 split of clinical and research. He's a consultant at the Clatterbridge Centre, Liverpool, which is one of 3 specialist cancer centres in the UK. He started his career as a cell and molecular biologist before retraining as a medical doctor. Your main interest research includes the biology of ageing and the developments of a test to recognise the last weeks and days of life. So we're very much looking forward to it.
So why am I here is because I'm from Sligo, and Anna asked me, and Anna is the person who said when she left in 2009 Sligo to go to Liverpool to do her GP training, said to me when I was a junior doctor, Seamus, you should apply for the palliative care Reg's job, which I did, and it was my first job. And even though I trained as a cell and molecular biologist, Anne-Marie Larkin, who's also in the audience, she was in the same lab when we did our PhDs together. So fellow Sligonians. So I've come to talk to you of what I've been working on for the last 10 years, which is kind of how do we die. And so my talk is kind of like, has got 2 parts. So I'll just talk mostly about my research, and then I'll spew some of my thoughts about being a clinician and doing research. So this is a painting of Socrates just before he kills himself with hemlock. And Plato is in the group amongst his other students. And one of them, when he took the hemlock and died, killed himself, he wrote down a description of how he died. And something I'm fond of very saying is 5,000 years of modern medicine, and actually the best we can do is describe it. And it's not much different to that painting and describing how Socrates died. So I'll be at the end of the bed, and I'll say, I think this person is dying. I think this person is dying, and yes, they're unconscious, they're dying. So, and they've got, secretions, or the breathing will go, and that's really the best that we can do. Now, the exceptions are, somebody who's dying from multi-organ failure in ITU, but that's not normally how people with cancer die. And if you do look at the post-mortem studies, and I've looked at the studies, and they say, well, people will die from a pulmonary embolus, so that's a clot on the lung. And it's what it's supposed to do, not that I have a pointer, is that red just above the heart, where you can see it going into both lungs, that's a saddle embolus. So a pulmonary embolus, which is in the lung, can develop into a saddle embolus. And it saddles both of the pulmonary arteries, and you'll die from that because there's no blood flow into the lungs. It's a saddle embolus. But most of the postmortems say you've had a pulmonary embolus, and they say, oh, you died from a PE. And they say the other common cause is that you have an infection. You go, all right, it was present in the lungs, they had an infection. But this is a study based from guys in the UK that I now know, and they've looked at the prevalence of a DVT, a deep vein thrombosis in the legs, and then PEs. And they said, yes, in the last weeks of life, a number of people have DVT and a PE. But that's not what they die from. They die with them. They happen to have them in the last weeks of life from their cancer, but that's not what they die from. And then there's this study from Paul Taylor in Sheffield. This is what he did his PhD on, and they looked at thousands of points. So they looked at all of the vitals and the bloods of people with cancer who are in hospital. And they said, right, they wanted to come up with an algorithm that predicted when people were dying. And so they looked at thousands of bloods from patients and their vitals, and all they could do would come up with saying that in the last 2 weeks of life, you've got deranged respiratory variables and deranged renal variables. So you don't die from renal failure, and you don't die from being unable to breathe. Your breathing's not as good. Maybe that's the PEs coming in. But they don't die from failure. And talking with Paul, he said actually there's a difference in the vitals of an acutely unwell patient to the patient who's deteriorating to dying. And in the acutely unwell patient, they'll become septic. So, and anybody who works in the hospital, they know all the Muse scores for predicting sepsis. But patients who are dying, even if they have an infection, they don't die from sepsis. They don't look septic. So what I've kind of distilled from the literature is actually, you don't die from organ failure. You might have an organ failure. It's not like going to ITU where you can die from multi-organ failure. But patients with cancer, in general, while they can die suddenly, it's unusual, they don't die from organ failure. And the bloods don't show it. They don't die from an infection. The vitals don't show it, and the bloods don't show it. And they don't die from a PE because they don't get a saddle embolus. And they don't die suddenly, which is what you expect. They die with them rather than from those events. So we did our own systematic review. I said, well, what are the biomarkers of dying? And there is no single biomarker that can say, well, actually, we think you are dying, which is the whole point. The recognition of dying is incredibly difficult. But what we found was that actually there was some raised inflammatory markers. So C-reactive protein can go up, but that doesn't help you when you're a clinician because you go, does this person have an infection? And that's the reason why their CRP is going up. Or does this person, is this their cancer? And with their cancer, their CRP goes up, and that doesn't help you predict that they're dying. And you get organ dysfunction, but not failure of the kidneys and the liver. And then you can get cachexia. So cachexia is this massive wasting of your muscles. The difference between fasting and so starvation and cachexia. So with fasting or starvation, you will lose fat first and you will try to preserve your muscle. But you will lose some of your muscle because your muscle is your protein store in the body. With cachexia, it doesn't care. You just lose everything. And you cannot rebuild muscle with the advanced cachexia. So given all the features that, if you ask anyone in palliative care, you can see someone who's dying. And Carmen, who was the previous ward sister in the hospice here, she would predict a week before, when I was, first in palliative care, she could predict a week before, she could see it a week before I could. And then one of the other doctors that was there after me going, oh my God, Carmen, she can tell people are dying a week before I can. And it wasn't just me, it was all the doctors. And I really reflected on that when I came up with the idea for this work. So, but there is this common set of things that we generally see to predict dying in palliative care. We like to think we're better at it than most others, but a lot of people miss them. So 5,000 years of medicine, we think there is a process to dying, and nobody's ever shown it, which is crazy. So I went to Liverpool. I didn't want to go to Liverpool, but I was in the interview for this job to become to do my consultancy training in palliative care. I didn't want to go to Ireland, but I couldn't get on the scheme in Ireland, so I went to Liverpool. And in the interview, I knew that the professor had an interest in the recognition of dying. So to try and impress him, I said, oh, you could come up with a urine test that predicts dying. And knowing that prof now, it went right over his head. But I got offered the post. I didn't realize I was the only person interviewed at the time, but I got offered the post. And then I realized, actually, that idea I came up with in the interview is more important than my desire to live close to my parents and be in Ireland. So I went and I said, let's do a proteomic study. Let's look at every single protein in the urine. And I went to a guy and he went, fantastic, it will cost you £200 a sample. You'll need 5 samples from a patient. That's £1,000. You'll need 20 patients. That's 20 grand. How much money do you have? I said, I don't have any. He went, good luck with that. And that afternoon I met a different prof. And he went, that's amazing. I've heard of animals that can smell when people are dying. I went, so have I. I've heard of, Catherine has told me about a dog in Our Lady's Hospice in Dublin. And this is Oscar the cat, whose face is in New England Journal of Medicine. And Oscar was an unsocial cat who would only go and lie on you if he knew you were dying. And it got to the point in this nursing home that whenever Oscar went onto someone's bed, they called the family. And so the prof said to me, well, that's what we do. We look at the sense of smell. Let's collect people's urine and we'll hunt for components of smell. So we did. We did a small study in 2014, 2015. I never published it because I thought, when I worked with Anne-Marie, at the time we were doing our PhD, we worked on something for years, and then they submitted a patent on the work that we were doing, and it turns out a month before we'd been working on it for years, 10, 15 people working on it, and a month before the patent went in, somebody else published it. So it became null and void. So I withheld what we published. But I got a Wellcome Trust Award for £1,000, or 100,000. And we collected urine just in people with lung cancer. And we got over 160 patients. It's actually closer to 300 now in the end. And over 60 in the last month of life. And we did what's called a metabolomic study. So what that means is we looked at every single, but as many metabolites as we could in the urine. So metabolite, glucose, amino acids, nucleic acids, any intermediate of Krebs cycle and glycolysis, things like that. And you put them through these fancy machines. The one on the top right is a gas chromatography mass spectrometer. So things are separated. If you remember your secondary school biology, you might have separated out chlorophyll, and that's chromatography. So you separate things out, you get the individual chemical, and then you identify it. And then, thankfully, we used the bottom left machine, which is an LC QTOF mass spec. Anyway, it's only $250,000 worth of a machine, but it's really cheap to use, so it was right in my budget. And so you take your urine, you put it through one of these mass specs, it comes out with hundreds of metabolites, and then you can kind of separate these out. These are the people in the last weeks of life, from people more than 100 days from death. And they were all lung cancer, but they were a mixed group of lung cancer. And, we came up with nearly 200 metabolites that change towards the end of life. And somebody has termed it the end-of-life metabolome. And we use different statistics. I'm not smart enough to know what the statistics are. I have to go with a statistician. And he tells me what to do. And then we do these things. But one of the things that we did was a Cox-Lassu regression analysis. And basically we looked at hundreds of metabolites. And with 8 of them, you could come up with a survival curve. And you can predict and say, well, actually, this person's got a low risk of dying, this person's got a medium risk of dying, and this person's got a high risk of dying. Some people have a very high risk of dying. And in this example here, you can see in red. So the bottom line is time, and that's in days. And then the y-axis is probability. And if you go up to, say, where it says 0.5, that's 50% of people have died. And they've all died within 10 days. So 50% of people in that high-risk group, they all died within a week. Everyone died within 3. That's much better than what we can do now. And that's just looking at someone's urine. It's because I asked the statistician, a very smart one, I don't have one area underneath the curve that tells you how accurate it is. I have one for every single day in the last week of life. So at 30 days out, it's nearly 90% accurate. At 17 days, it's nearly 90% accurate. And then it kind of wobbles in the last. So it's not a test that at 30 days out, it's nearly 90% accurate. It's a test that actually for every single day within the last month of life. But we calibrated at days 30, at days 20, and days 10. We don't have enough numbers in the last 10 days to really get a full sense. We haven't validated that, so what I mean is that we've taken all of our samples and we're going, what's the best possible outcome for that group? What you're supposed to do now is then get a completely independent group and then see if that model works on them. And we're doing that at the minute. The hospital that I work that does that, they moved during the summer. How dare they? It's a £250,000 machine, so it stopped working for a number of months. But it is working, so the machine's got analysed over the weekend. So unfortunately, I don't have the results to share with you. But one of the things that we found was we looked at all of these metabolites, and these all changed. And you go, well, wow. So some of the things that you could infer from it was you go, well, it's not surprising. You can see the decreased oral intake. So my wife is a palliative care nurse in Liverpool, and you can see that caffeine goes down, and it goes down in the second last week of life. Now, it's obvious in the last days of life when somebody's not drinking their cup of tea, but a week out when they're drinking half a cup of tea, it's harder to notice. But so this is a box plot, and if you think of the pink as being the box, and then those are the outliers from a normal distribution. And so what's in red is the last week of life. What's in purple is more than 3 months out. So you can see that trend for it to decrease, which you kind of expect. And then this is cortisol and adrenaline. Cortisol goes up pretty much in the last week of life. Now, I'd like to say I'm the first person to ever show that, but no, it's not true. Some guys in 1956 showed that with lung diseases from death, that happened to be lung, they had a few with lung cancer, they show that cortisol goes up towards dying. Nobody's ever showed that adrenaline goes up in the last weeks of life. And then you can see massive cachexia. So creatine, which the bodybuilders eat, what is that doing in your urine in the last 3 weeks of life? You know, it's the breakdown of the muscle. And there's other ones, sarcosine, carnosine, and various others. So this massive cachexia, it's not really surprising when I think about it now. When in palliative care, there's that massive weight loss, but it's difficult to see that in the individual in front of you. And then you see all these chemicals, you look them up and you go, I've never heard of that one before, and that one happens to be chynuric acid, and that goes up during inflammation, so it ties with the C-reactive protein. And again, it goes up in particular the last week of life. This isn't what's widely known. So mitochondrial dysfunction. You go, well, what if you're not producing as much energy as you normally would? You're breaking down all your muscle and your fat. Is that cachexia? What's the reason behind that? We don't know. And what we also showed, or we strongly suspect, is that you got all of these building blocks. Let's make this wall. So this wall is a protein, but the building blocks are the bricks. You go, well, we're finding the bricks, but we're not finding the walls. We strongly suspect that for a variety of reasons, you're not making the messenger RNA and you're not making the proteins. You know, what's going on? And, you know, we've got evidence that there's various perturbed other pathways going on. And one of the things then to kind of back up what we showed was said, well, we think you're losing a lot of fat. So when anybody who goes on a ketogenic diet, they've got bad breath. That's acetone. And we found acetone in the urine towards last days of life in particular. And somebody who's really serious about the ketogenic diet will test their blood. So you just use the ketone meter that people with diabetes they get a pathological increase in ketones for their ketoacidosis. But if you starve yourself and just eat fat, you will still produce what's called ketones, or ketone bodies. And actually we did that. We did that with a mixed group of cancer patients, and we measured their blood, just a drop of blood with their ketone meter. And what you can see is this is just all in 3 groupings, but on the right is the last 3 days of life. And you can see this group of people where most people, their ketones go up. And that seems to happen in the last few days of life. There's another group of people where it goes up 3 weeks beforehand. And a lot of those people are the likes of people with esophageal cancer who don't eat. And one of those people is, it's only when it started to decrease that person died. It's almost like following a starvation pathway. So it suggests that there are different modes of dying, but I like to think there's a lot of things that are similar. So kind of a quick summary, there's ketone changes, there's mitochondrial dysfunction, you can see the cachexia, we think there's decreased protein production, and various other aberrations of biochemistry within the cell. And hopefully we'll publish in the new year once we validate our work. And then we have created this model that predicts dying. We patented it in March of this year, and that's now, we're trying to develop a hospital-based test, a 96-well plate colorimetric test. And what I just discussed is we're just starting to explore the physiology of dying. So kind of reflections. I'm not keeping track of time, but I only have a few slides left. Who are you not to do research? Any of you? So the quote is, "You playing small does not serve the world. Who are you not to be great?" It's variously attributed to Nelson Mandela incorrectly. It's Marianne Williamson. But you don't need to know how to do research. That's not your job. For those clinicians in the audience, your job is not to be a researcher. Your job is your insight. The research, there's plenty of people who know how to do research. Your job is to go, actually, this bugs me. Why is this? And then you will talk to a researcher, and the researcher goes, what's that? Why is that important? And you will explain it to them. So it's your insight is invaluable. And before I studied medicine in my early 30s, my prof at the time said, doctors have great science, but, or great ideas, but poor science. And I'd like to change that to clinicians. Scientists have poor ideas, but they've got great science, and they're the ones who get funded. And, these are the steps I've taken. Yes, I'm a trained researcher. What it meant was, I knew that you could look for a needle in a haystack. I knew an omics study would find, well, I really hoped an omics study, and this happens to be metabolomics, would find what I suspected. But you don't need to. It's the insight. Can we predict the last weeks of life? When, it took me a long time to say that. You go, well, someone who's dying from breast cancer looks the same as someone dying from lung cancer, to someone who's dying from a pneumonia, to someone who's dying from a stroke. In a lot of ways. I'm sure the final pathways, it's not completely the same, but it's very similar. And that was my question. That was my insight. I think there's a process. We can analyze it. There you go. That's where I started from. Then I found, I talked to others, so I told you the proteomics study, and then you met Oscar the cat. So I found a researcher who knew what to do. So the hard bit then was being a lab scientist, writing an ethics proposal. That was painful, I admit. It took me a year, part-time. But we collected the urine. We did our feasibility study, and then you get the grants. And you don't need to know how to do the analysis. Somebody in the lab does. And if they don't know how to do it, they know a statistician who does. So you don't need to know it. And you can get these grants if your idea is good enough. And what I would say to you is that writing ethics, writing grants, and writing publications, that nobody is good at these things. And it is perfectly acceptable to think, there is no way on earth that I can ever do these things. And I would say to you that if you're passionate about what you are doing, you'll learn how to do it. And then it becomes, I'll stop short of a joy, but then you become really enthused. You say, actually, this is really important to me. And there's things that you learn along the way, but they're not what should stop. Don't let that stop you from getting into research. Your idea is what's important. And if you believe in the importance of your insight, then there's always a way. Others will believe in it as well. And because I've believed in mine, I've recruited over 300 people from different hospitals and hospices across the northwest coast in the UK, got a patent. We're going to develop a hospital test. There's a whole new avenue of scientific research. And I don't think I'm about to get publications. And those are the grants that I've gotten so far. I don't think I'm that special. You can do it too. Thank you.
Thank you, Seamus. That was hugely interesting. Does anybody have any questions for Seamus? Of course, Anna has.
That's your job, Anna. You're the chairperson.
I have lots of questions. First of all, just interesting, what kind of, when you go to a patient, you say, I'm doing this research, and it's all about predicting death. How do they respond, or how do you phrase it?
Not like that. So, did I tell you that it took me a year to write the ethics application? So, when you say to people that we're starting to look at the effect of the cancer on the body. And that we want people who've got early disease, and we need people towards the end of the disease. And then I'm up front. I'm saying, in particular, I'm interested in how we die. You know, the recruitment rate was huge, like 80% plus. You know, when you have people that you approach, it's often much less. So we were putting them out by getting the urine. And then with the ketone studying, we were getting a drop of blood. And it wasn't just one. You know, it was a few times, twice a week, for as long as they were an inpatient. Next question.
Anyone else?
I'm not a medical person, so I probably misunderstood, or I sort of understand what you're saying, but it seems to me that what you're saying is that people die almost because the body starts crumbling away at the last point. Is that, I mean, that it sort of just starts to break down in a sense, and it creates these different chemicals then that we can detect. And do we know why it starts to break down in that way at that point? Because you said lots of people think that it's other things, which it isn't. It seems to be this disintegration, this sort of quick disintegration. Would that be the right interpretation, or am I completely wrong?
Your interpretation is as good as mine. So I would almost say, and I don't have full evidence to back this up, that it's almost like a shutting down. And then because things shut down, then maybe things disintegrate. And my oncology colleagues are interested in, wow, fantastic, you can predict dying. Well, they're not interested in the palliative care, but they're interested in, well, if you can prevent that tipping point, then you can keep someone alive longer. Haven't found that tipping point. But, one of my best friends, his dad was elderly, he's from Mayo, a farmer from Mayo. And he described the last weeks of his life. He said, he reached his late 80s. And in the last 3 weeks of his life, he faded and died. And I think, from what we see tentatively, something is happening 2 and 3 weeks out. At the minute, if you're in a hospital, and I can quote UK statistics, it's difficult to recognize the last 2 or 3 days that someone's in the last, 2 or 3 days of life. Never mind 2 to 3 weeks out. So I think it's happening there. There's a long-winded answer. Normally in the UK, I'd say, ask an Irishman a question, you deserve a long answer.
And did they ever find out what the cat was detecting?
No. Well, how do you ask a cat? But we found, say, we're about to submit our paper next week, so you kind of go, well, actually, there's 10 that increase. One of them is acetone. And all the rest are all of these weird and wonderful chemicals. I haven't a clue what they are. And you go onto the internet and nobody else knows what they are either. That's the problem with the GC, the gas chromatography work, and looking at the components of smell. Nobody knows what they are or where they come from. And thankfully we did that second body of work, and everybody can recognize, creatine and sarcosine. And at least we know what they are. So we've been able to explore some of what we think, some of the biology of what's going on.
You've just answered my question.
Okay. Any further questions? Barry.
Hi, Barry. Or
Where did you come out of?
Sorry, Seamus, I just snuck in there at the end. How are you, Seamus?
I saw you sneaking in.
I haven't seen you in a long time. So, Seamus, have you done any studies looking at the qualitative, you speak about the Carmens of this world, that we all know that can see these things. Have you correlated your urines with, is there any study to perceive, like, for example, nurses or caregivers' perceptions of a patient? That it's hard to measure it, but, we often see that as a warning shot that someone who knows them well says they're in trouble or whatever.
But all of the studies, some of the guys at MD Anderson and some of the guys in Liverpool, they're all looking at, nasolabial fold decrease, the movement of the mandibular jaw when you breathe, terminal secretions. Nothing like what Carmen could do. and I think Carmen had a sixth sense, and as many nurses do. But what I think she was seeing, and it was probably blatantly obvious to her, was that, look at that person, they're becoming more and more cachectic. And I definitely see that now. And you go, actually, the urine is backing that up. Look at all the creatine, sarcosine, and other muscle metabolites in the urine. Don't know if I've answered. So the answer is no. And when we were collecting the urine, we asked, was the person actively dying? Which, and yes, you can separate out the people who are actively dying, and then tentatively we can separate out. So there's nowhere in the literature. So you and I know, and all the other palliative care guys in the audience know that, we don't say to people, oh, you probably got about 2 or 3 days to live. You don't, because you know that some people die within a day. So some people, most people, when you see that they're actively dying, will die over 2 to 3 days. But we hold back, and you go, well, I've seen people who've had breakfast, and then they've gone through all of the stages of dying and died that night. And then there's the other small group of patients who you go, oh, you'll die in 2 or 3 days, and then they stay on the cusp of death for like a week, highly distressing for their family, and then they die. And you go, there's nowhere in the literature that it describes that. But actually, we've done some subgroup analysis that says, well, actually, I can separate out the guys who die over 2 to 3 days, and for some reason, the guys who die in a day and those guys who die over a week, they kind of join together.
Thanks, Sean.
Watch this space.
Okay,
Am I free to go?
I think so.
Thank you.